Hello, this is Gershon Zinger, and this talk is about ulnar-sided wrist pain. Ulnar wrist pain is a huge subject. In 20 minutes, I hope to give you a perspective of the problem with a focus on both the physical exam for ulnar-sided wrist pain and also with a focus on the TFCC, the triangular fibrocartilage complex. The word wrist originates from its unique twist mechanism. If you look, the ulna is fixed and the radius rotates around it. The unique twist mechanism, combined with the lack of osseous stability of the DRUJ, the distal radial ulnar joint, places the demands for stability on the surrounding soft tissue. The ulnar soft tissue, and specifically the TFCC, with its foveal attachment, serve as the pivot point for forearm and wrist rotation. The ulnar soft tissue is a complex anatomy, and when injured or worn can be a source of pain. The challenge in ulnar wrist pain starts with proper diagnosis. There are two reasons why it can be difficult. The first is that there is a lot of stuff in a small space. Here are a few examples. LT ligament tear, ulnar impaction, ulnocarpal ligament tear, TFCC tear, DRUJ arthritis or instability, ECU tendinitis, and more. And each condition is a different diagnosis and requires a different treatment. This is the second reason that diagnosis can be challenging. There are many studies that can be ordered, but to know the right study, you already need the correct diagnosis from the exam. The studies listed here are not used to make the diagnosis, but rather to confirm the diagnosis. Having said that, the two most helpful and common studies are plain X-ray and MRI. Though soft tissue does not appear on X-ray, many conditions will. This slide, for example, shows a vascular necrosis of the lunate known as Kienbock's disease. When it comes to MRI, there are many different techniques. Fortunately, at our institution, we provide the suspected diagnosis and the radiologist will determine the ideal methodology. So the challenges of ulnar wrist pain include many different conditions that are close together and imaging studies that don't by themselves give the diagnosis. So how do we get the diagnosis? Well, the old-fashioned way, history and physical exam. For me, the most important part of the physical exam is at the beginning. When a patient is asked to point to where their pain is worst, I can often tell if I will be able to help them. If they circle the entire wrist, this is not a good sign. On the other hand, if they point to a specific spot, starts the differential diagnosis. And since it orients the examiner to the local anatomy, these patients can often be helped. Let's focus on different conditions, describe the pathology in the physical exam, and let's begin with the LT, the lunotriquetral ligament. On the left is an intraoperative view. It shows a tear of the LT ligament. On the right is an arthroscopic view through the mid-carpal portal. It shows a stable LT interval. The clinical exam for LT ligament tear involves grasping the lunate in one hand and the triquetrum in the other and trying to move them in opposite directions. There are at least two tests for LT instability. The first and most common is shown here. With the Regan LT shuck test, in one hand the pisiform and triquetrum are grasped. That's on the right hand, the examiner's right hand, and with the other hand the lunate is grasped. The test is moving them in opposite directions, volar and dorsal. The Kleinman shear test also translates the lunate and triquetrum in opposite directions, but gives a little bit more control. The thumbs are on opposite sides of the wrist compared to the Regan shuck test, and instead of pulling and pushing, the test involves just pushing, but in opposite directions. The ECU tendon can have two different reasons for pain. It can get inflamed and it can also be unstable. This is a test for inflammation. The wrist is placed in supination and then extension is actively resisted. This is a test for ECU instability. The ECU tendon lies within a separate subsheath, like a box within a box. The inner container has a tear, and the tendon will sublux over the ulnar head with certain movements. This is a provocative maneuver to sublux the tendon. The tendon subluxes as the wrist is moved into pronation and flexion. Sometimes the styloid of the ulna is unusually long, or more commonly it can be displaced after a fracture. The styloid tip can impinge in certain positions with the triquetrum, and this passive maneuver tests for impingement. The DRUJ, the distal radial ulnar joint, can get inflamed, arthritic, or become unstable. This compression test is for pain from the joint for any of these conditions. Instability of the DRUJ needs to be checked in pronation, neutral, and supination. When the wrist is supinated, the volar capsule is tight. So is the volar superficial and deep dorsal radial ulnar ligaments. The opposite is true in pronation. So if there is instability in supination, then the deep dorsal is really the problem, since the deep RU ligaments are the ones that provide stability. More on that later when we show the TFCC. CT is the best way to evaluate DRUJ instability. Regular x-rays are not reliable. One should order limited cuts through the DRUJ of both wrists in pronation, neutral, and supination. There are different radiographic criteria for diagnosis, and this too is not exact, since there is a lot of variability in the amount of translation. Here is an example of volar subluxation in supination. Looking at the bottom two images, the image on the right is normal, and the image on the left shows a volar subluxation of the ulna. Though really the radius is the one moving, we define the direction of instability based on the direction of the ulna. Stabilization of the DRUJ may require repair of the TFCC, or rarely reconstruction of both the volar and dorsal radial ulnar ligaments. Graft is taken, typically the palmaris longus, and the tendon is passed through the distal radius and through the fovea of the ulna. The intent here is to recreate the V of the DRUJ ligament complex, that is both the volar and dorsal radial ulnar ligaments. Note here that the fovea is along the center of the axis of the ulna. This is the attachment of the deep fibers of the TFCC. Ulnocarpal impaction can occur when the ulna is long relative to the radius. This can cause pain along the lunate and ulnar head. Exam shows local tenderness and pain with the impaction test, which will be shown shortly. The MRI can confirm the diagnosis, with changes visible within the marrow of the lunate. The solution is to unload the ulnar wrist. We shorten the ulna so that there is less pressure between the lunate and the ulnar head, and less force across the ulnar wrist. This also tightens the ulnocarpal ligaments. One has to be careful when shortening an ulna when the sigmoid notch has a reverse obliquity, that is when the orientation is upward and not downward. Acumed has a plate system that allows both very precise shortening based on the pre-op x-rays. The amount of shortening is determined. The saw guide is used to make the first cut, and then move proximal to make second cut. Here, a 2 mm segment of bone was removed. The system includes a special clamp to compress the fragments together. I have nothing to disclose with regards to Acumed. There are other systems available as well. Now let's look at the volar side of the wrist, the piezotriquetral joint. The pisiform for the wrist is like the patella in the knee. It can give a mechanical advantage to the tendon, in this case the FCU, the flexor carpi ulnaris. Pain at the piezotriquetral joint can be from a loose body or from arthritis. It is tested with compression and translation. Another way to load the piezotriquetral joint is resisted small finger abduction. When conservative treatment fails, one option is removal of the pisiform. Hamate injuries can occur with trauma. Injury is suggested by local tenderness and confirmed with CT scan. Sometimes selective injections can be helpful. Typically this is done with both lidocaine and steroid mixed together. But it is important to remember that since things are so close together, injection of one area may also anesthetize another. Let's focus for a few minutes on the TFCC. The complex includes all the components listed: central disc, DRUJ ligaments, The disc has a superficial part here in green and a deep part here in blue. The superficial part inserts on the styloid and the deep part on the fovea. The deep part can include the stabilizing radio-ulnar ligaments and the insertion into the fovea called the ligamentum subcruentum. Not really a ligament, but rather the attachment. The ulnocarpal ligaments and ECU subsheath are better seen on an upcoming slide. Looking from above, you can see the V shape of the complex. In the middle is the central disc, CD. The central disc is like the meniscus in the knee. It bears load, but does not contribute to DRUJ stability, which is provided by the D dorsal radial ulnar ligament and the V volar radial ulnar ligaments. The ulnocarpal ligaments here, the UL, the ulnolunate, and the UT, the ulnotriquetral ligaments, originate not from the moving ulnar head, but rather from the volar deep part of the TFCC. The dorsal ECU sheath is also part of the TFC complex. When the TFCC has a peripheral tear and an arthroscopic repair is done, the TFCC is repaired to this ECU subsheath. Note how the superficial part of the TFCC attaches to the styloid, but the deeper part attaches to the fovea. So how do we evaluate for TFCC pain? The ulna fovea sign is pressure in the space between the ECU dorsal and the FCU volar in the ulnocarpal space. In the ulnocarpal stress test, the TFCC is loaded and involves ulnar deviation, compression, and rotation. The Palmer classification for acute tears of the TFCC include 1A, which is a central tear, and 1B, which is a peripheral tear. These are the most common. Similar to the meniscus in the knee, central tears are debrided because there is little blood supply for healing, and peripheral tears are typically repaired. MRI is typically used to confirm tears of the TFCC. It is important to know that MRI is not a perfect test. It can miss tears, called sensitivity, and sometimes the image will suggest a tear when there is none, called specificity. The trampoline test checks the TFCC tension. If the TFCC is torn, the tension goes from trampoline to a soft pillow, and the probe sinks instead of bounces. The tug test is used to check the deep attachment of the TFCC. Here you can see the probe trying to pull the TFCC upward. It is important to know that the TFCC wears as we age. In this classic anatomic article from 1978, Mikic looked at 180 cadaver specimens from infants to old age and studied both gross appearance and microscopic structure. The TFCC started to wear after age 30, and by age 50, none were completely normal. Now, we don't know if these individuals had pain, but we do know that it can be normal after age 50 to have perforations or holes in the TFCC. The left side shows a perforation in a 50-year-old, and the right side shows shredding of the TFCC in a 77-year-old. Similar to the anatomic findings, MRI done in asymptomatic wrists, people without pain, shows a similar increase in abnormal findings as we age. The older the patient, the more likely it is to find an abnormal TFCC, and this may not be the source of their pain. Also, just because they have a TFCC on MRI does not mean that it requires surgical treatment. With this in mind, treatment of pain thought to be coming from the TFCC can be treated conservatively to start. For an acute injury, casting may allow it to heal. For a chronic pain or degenerative tear or wear, then options aimed at reducing pain and inflammation can be successful. Operative treatment includes arthroscopic treatment of a central tear or repair of a peripheral tear. Results of surgery show success rates of 70 to 90% of TFCC debridement or repair. With arthroscopic techniques, the TFCC is typically repaired to soft tissue, specifically the ECU subsheath. When there is a combination of TFCC peripheral tear and DRUJ instability, the TFCC is best repaired directly to bone, to the fovea. This is typically done with an open technique seen on the right. Arthroscopic techniques to repair the TFCC to bone until recently used a combination of osseous tunnels and arthroscopic suture techniques. Recently, there are knotless repair systems that are all inside techniques. There are not many studies that show clinical results, but it may be promising. Before we finish, it's important to know that I've not discussed all the potential causes of ulnar-sided wrist pain. One should be alert for other causes. Here are just a few examples. A ganglion cyst with fluid under pressure can cause pain. Inflammatory conditions like rheumatoid arthritis can certainly cause pain and may not be obvious in early stages. Pseudogout can have pathognomonic chondrocalcinosis. Intraosseous cysts can be benign, but when they break out the side can be a source of pain. And there are other more unusual causes of wrist pain that require specific evaluation and treatment, such as nerve-related, vascular, infection, tumor, PVNS, and other. We're almost done. In summary, ulnar wrist pain has many potential causes. The key to diagnosis is an accurate history and physical exam. MRI is not completely reliable. And though injuries to the TFCC may be the most common cause of ulnar-sided wrist pain, natural wear must be considered. The anatomy is complex and treatment can be difficult. I hope that I've been able to give you a perspective of ulnar wrist pain. The more I learn, the more I realize how much I have yet to learn. Thanks for your attention.